For those that I don't know out there in Zoomland, I've been in health systems, part of the School of Population Health for the last 15 years. Originally, I guess my topic area is health policy and public policy, and I have been involved in research in this broad area about what we might call performance management in the health sector since about 2010. And so a number of the research projects I've been involved in have been about this in collaboration with many other people. And I just thought it's an interesting time in New Zealand health policy history at the moment. We've had 10 years of experience with, or slightly more than 10 years experience with different types of performance management. And the interesting question is what's going to come next. More on that later. But my focus is to just look at what we can tell from what has happened. So what I'd like to do is talk about what this term performance management means, and then so we'll just use the abbreviation PM to talk. And then I'll talk about sort of some general conceptual issues, and then specifically talk about the what has happened in the health sector in New Zealand, and specifically get into two, I guess, regimes of performance management. The first being the health targets, the national health targets, and the second being system level measures. And I want to ask a question which will become, the meaning of which will become apparent as we go, which is, can we have our cake and eat it when it comes to performance management? See what that means in a moment. So, first of all, what is performance management? And I'm the material I'm talking about is a lot of things that many people here will recognise, but maybe give it somewhat different names. The name that I'm using is from, I guess, what we would call public management or public sector management studies or literature, or what used to be called public administration. There's a pretty influential textbook in that area by Walter van Doren and a couple of colleagues, and they define performance management as a type of management that incorporates and uses performance information for decision making. And so there's a few implications of that definition. I think it's a pretty good definition. It's not just about measuring performance, and it must at some level be about some outcomes that people value. And I think it also requires some sort of feedback loop between the measurement and the reporting on performance that is meant to ideally improve performance. Now, I would love to have a longer discussion on what we mean by performance, but I'm not sure I've got time for that here, but if you want to ask that question a bit later, please do. It's a very interesting word, actually. And the other sort of the fourth implication is that we're not just talking about financial performance, so whether DHBs or BHOs, you know, kind of are in deficit or not. Much bigger than that. Now, this whole area of performance management is actually taps into some fundamental, I guess, questions in social science more generally, or at least how society or how organisations are coordinated, or how systems are coordinated, including health systems. And so there's basically one of the things that Van Doren and his colleagues do in their textbook is talk about the different purposes of performance management. And they distinguish between performance management for accountability and performance management for learning. They have a third category as well, but that seems to have disappeared over the years. So I'll just talk about those two. And they happen to, I guess, purposes of performance management really map onto different ideas about how things should be coordinated, how social activity should be coordinated, whether it should be done in terms of hierarchical arrangements or whether it should be done through some sort of collaborative networking. So you can sort of, the enduring dilemma is basically what sort of form of performance management do you have? So there's sort of two broad logics here. And the first sort of in public management literature goes under the name New Public Management. And it is focused on accountability to external stakeholders, the minister, the public. It tends to prefer to use outputs and processes as indicators. So, you know, the amount of, we can use examples later, but the health targets would be classical examples here. We'll talk more about that later. And it tends to sort of rely on authority and the capacity to command and control, and associated with that, it draws on extrinsic motivation in the use of sanctions for performance or non-performance. And counterposed to that, I guess, is the idea of performance management for learning, which utilises sort of more network coordination, emphasises learning and improvement. The audience is more internal. So if we think of quality improvement regimes in primary care, the audience is primary care practitioners themselves rather than the people that pay them. And the emphasis may, or no, not always, but tends to shift more towards what outcomes are important, and tends to be a process more built on stakeholder buy-in, collegiality, not sanctions, and is therefore sort of related to intrinsic motivation. There's a word for this in public management literature, or a term that's related, which is new public governance, which is often contrasted to new public management. So, big question then is sort of the idea of a feedback loop. This is sort of a very basic attempt to map what a feedback loop would look like. And so public management talk, there's a lot there's a distinguishing between, I guess, processes, outputs, and outcomes. And so I use the metaphor of a cake. So generally we do things in health systems in order to have better outcomes of some sort, whether that's better population health, or might sort of specify that in terms of, you know, you know, we might think of screening rates, or, well, screening rate, population health screening is more a process, or the number of people screened for a particular cancer. That's an output. The outcome is reduced mortality or morbidity from a particular cancer. So in the cake metaphor, it's you know, the cake itself is the output, but the satisfaction of the person eating the cake is the outcome. Of course, we've got the processes of making the cake, and of course the inputs, the ingredients in there as well. So the basic question in any regime of performance management is where to start. And we've seen some different ideas about this over the years. The other thing to note, of course, and it's pretty obvious as soon as you think about it, is that there are many other things that might influence outcomes. For example, whether this girl is happy with the cake might depend a little bit on whether she's allergic to eggs, quite independently of whether the cake is made well, whether it's a great cake. So we'll just sort of come back to that point, of course, a bit later, but that turns out to be pretty fundamental, of course. So we talk about these two broad ways of thinking about performance management, or doing performance management, and I'm aware that many people in the health sector will say the second one, what we're calling performance management for learning, shouldn't be called performance management. We can have that discussion. I'm quite happy to have that discussion later. We say we should call it quality improvement or something like that. But I'm using public management terminology for the moment because it covers both. So the case for performance management for accountability is that it can stimulate real improvement, it provides clarity of expectations, and the indicators, whether they're outputs or processes, are things that are within the control of, I guess, the people, the organisation, the practitioners that are accountable. It doesn't make sense to hold them accountable for things they are not controlled. The case against, more broadly, and this is from more recent work by Van Doren and Hoffman, is they talk about sort of three, I guess, negative effects potentially of performance management for accountability. One is futility, that people do stuff because of the performance management regime, but actually it's stuff that doesn't really lead to anything. The second, that we'll talk about some examples of that later. The second is what they call jeopardy, and that's the category that involves gaming and cheating, gaming the performance measure basically, or outright cheating. And the third is what they call perversity, which is the sort of behaviour that can result from things like health targets, such as hitting targets but missing points, the things that aren't done because the target is focused on, and the narrow vision that often is associated with trying to achieve a target. So that's broadly the case for and the case against performance management for accountability, of which we'll see targets fits into that category. The alternative for performance management for learning is in a sense, in many ways, the direct opposite. Case 4 stimulates inter-organisational collaboration. If more than one organisation or practice or service is involved in influencing outcomes, then you need collaboration across organisations. It builds more on intrinsic motivation. It draws on, warm fuzzy things such as open dialogue, problem solving, spirit of inquiry. It's supposed to generate virtuous circles of trust, and it may even, done really well, facilitate double loop learning, and sort of fit the logic of what happens in complex adaptive systems. Won't talk too much about that, but the case against is that good performance is not mandatory; it's voluntary. And here you might some of you may have come across the work of Julian Legrand, famous English academic, who talks in a very English way, in a very male way, about knights and knaves. And in relation to the health sector, he says, well, traditionally we've assumed in the health sector that all health practitioners are knights, but why should we? Many of them, most of them might be, but some of them might be knaves. So if some of them are knaves, we may not necessarily need to we may need to build in other things other than trust. Diffused responsibility that often goes with performance management for learning can also mean no accountability. If everybody's responsible for some things but not everything, no one is responsible for everything. There are, of course, huge problems in attributing changes to indicators, particularly if those indicators are outcome indicators. And there's no guarantee that good practice performance scales up and spreads even when it does occur. So those are sort of the broad arguments that can if you're interested in the origins of those, I can give you some pointers later. So the next question is, can you have a performance management regime that does both, that facilitates accountability and learning? And here are two sort of takes on that. One is from Van Doren and Hoffman, who I've mentioned already. And for them, the answer is most definitely no. And they, I'll sort of put it this way, they said, as soon as you try and introduce any accountability into a performance management regime, the opportunities for learning plummet. So it's following this dotted line here. So they would say you definitely cannot have your cake, your performance management cake, and eat it. A different take on this, or it's an implication of some more recent work done in by a couple of Scottish authors, and they were looking at a number of performance management initiatives in the Scottish health system. And their answer is, yes, it is possible to have your cake and eat it. It depends on the type of thing that is being monitored. So they contrast, say, something like an infection control initiative in hospitals to an initiative that's aimed at trying to, what's the second one I'm trying to read here, shifting the balance of care from hospitals to primary care, which they say is a very complex thing to do. Their means are ambiguous, the ends are contested, it's a wicked problem, whereas infection control, people agree it's a good idea, not many people don't, and people know how to do it. So in that sort of case, you could have a performance management regime that could facilitate both accountability and learning. We'll return to that a little bit later. So when we're looking at performance management regimes, I guess here are the key questions that we want to ask. Firstly, does a performance management regime work? If so, how? Does it change behaviour? Is it able to generate a performance feedback loop? And might do all those things, might do them well, but might also produce other consequences which may be. So let's now locate this whole debate in the context of the New Zealand health sector. So some important sort of caveats. Health systems, perhaps more than any other sector of society, are dominated or are built on the power of professionals. It's not an unlimited power, but it's pretty significant. Health systems are created by professionals. They're created in a way that suits professionals, and therefore any attempt to manage performance must deal with that reality. And an important feature of professionalism is the emphasis on intrinsic motivation over extrinsic motivation. And within health systems, we see, of course, the growth of quality improvement within health as a significant, which is quite separate to the, but sort of joins sort of efforts in performance management more broadly. But, and this appears much more consistent with PM, performance management for learning. So I guess the classic figure in New Zealand that would be associated with that perspective would be Les Toop, who would be a trenchant critic of, say, the quality outcomes framework in the UK and the health target regime in New Zealand. In the New Zealand public sector, more broadly, we are known for having a very strong emphasis on new public management, and new public management, without going into too much detail, is a system of public management which is basically fundamentally built on the idea of distrust. Now, I'm not necessarily saying that's a bad thing, but that is essentially what it is all about. So, rather than, another aphorism can be what you can trust but verify, is the old, and the verification is the important thing. So, that's been entrenched over the last 30 years, and I guess its competitor, new public governance, is present in some parts of the state sector, but it is patchy, doing things in a more collaborative way, more based on trust. In the health system in 2020 or 2021, I should say, both those models of public management are manifest in the Ministry of Health. You can go to different parts of the Ministry of Health and they will take completely opposing positions on how the health sector should be managed. And you'll find that in DHBs as well. And if we look at the Simpson report, the final report of the Health and Disability Review, of course, there's something even more disturbing in that, which they use the phrase accountability for outcomes, which in my view is probably the worst of both worlds. But you may disagree with me on that, and I'm happy for you to do that. So here's a brief history of what's happened in performance management in the New Zealand health sector. It sort of goes back to about 2005. So probably the beginnings of pay for performance in primary care. I haven't talked too much about pay for performance, sort of in the background here a bit. But the health targets, as we know them, really go back to 2009, and when Tony Ryle became Minister of Health. So he picked up on something that Steve McKernan, as Director General of the Ministry of Health, had introduced internally into the ministry in DHBs in 2007 and made them more public-facing thing. Under National, we also had Better Public Services, which was, I guess, a Bill English sort of initiative as Treasurer, and it had a different sort of flavour to the health targets. And then over time, we had the IPIF proposal in health, which never actually came to fruition, but some of it survived in the form of system-level measures that were introduced in 2016, and we're going to talk about them in a minute. So here's a brief reminder of the targets. This only feels like yesterday. I've had word from somebody deeply involved in this that some form of targets may be coming back very soon. So there were the 6 targets, of course. Sometimes they were changed over time, the definition of the targets. Some of them were quite difficult to define, particularly the ones around cardiovascular disease and diabetes. But whatever they were, there was public reporting of performance and ranking, and it was very much in the realm of performance management for accountability, mainly because, not because there were necessarily very clear sanctions for not performing, but chief executives of DHBs certainly feared the phone call from the minister, and that seemed to be enough. And then we have more recently, so the targets sort of petered out in about 2018. David Clark, the minister, said he didn't use them anymore, but the information is still collected. But in 2016, it was still under National, under Jonathan Coleman as minister, the system level measures framework was introduced. And this, on the face of it, may look similar, but it is actually very different. You can see the sort of the measures on the left-hand side. Not all of them, but some of them are outcome measures, and a couple of these are the subject of Pushkar's PhD, and he's the go-to person for these. And some of them are less outcome measures and more something else. But what is really noticeable is the difference between the logics of how they work. So the targets is do this or else, you work out how to do it, but do it or else you will be held accountable. The system level measures is more about stimulating collective problem solving, about, well, if we've got a rate of ambulatory sensitive hospitalisation for young kids, how do DHBs and PHOs work collectively, collaboratively to work out what to do to reduce that rate? And there's no sticks and no carrots really. It's simply persuasion is the kind of the tool of government really. So this seems to be a series of natural experiments basically for our bigger question. Health targets and to a lesser extent pay for performance in primary care. Classic examples of performance management for accountability. Some would argue that the health targets were about learning as well, so let's see. But certainly system level measures, talk to the people that promoted that within the Ministry of Health, they would say this is definitely about performance management for learning. In fact, they don't even like the term performance management. They certainly would say it's about learning. And so it's a great opportunity to look at this question. So what research has been done? Well, into health targets quite a bit, into system level measures a little bit. So we've got more on one than the other, but I guess we'll just have to go with that for the moment. So the ED target was a focus of a HRC funded research project, which involved Peter Jones from Auckland Hospital at the time, because also has a part-time appointment at the School of Medicine. Linda Chalmers, PhD student, and the cast of many people in School of Population Health. Child immunisation target was the focus of Esther Willings, PhD, in the School of Population Health. The elective surgery target was the subject of a PhD thesis done by Corinne Gower at Victoria University of Wellington. The more heart and diabetes checks target was evaluated by a consultancy, Allen and Clark, a few years ago. And I'll just throw it in, although I haven't included it, there was an honours project on the smoking cessation target by Reese Vaughan-Jones, but I haven't included that in here. The cancer target, Rob will probably want to say something about that. It certainly was not, I have not seen any evaluations of the cancer target at any point, which is a shame. System level measures, we had a faculty research development fund grant a couple of years ago, which a number of people here were involved in. And so we can say a few things about that. And a lot of that material is just about to come out. Research from that. So let's look at the targets and let's take them one by one, because I think this is important to do rather than as a group. We can do that. So let's go through those questions. So did the ED target catalyse improved performance? Well, yes, Peter Jones' research suggests that, sort of if you compare before and after the target, hundreds of lives were saved due to the introduction of the ED target. How did that happen? Well, there were a lot of initiatives early on, particularly aimed at improving patient flow, and they definitely had an effect. DHBs gave more resources to EDs to implement the target at a time where there was no additional money going into the health system, basically, per capita anyway. So that's basically sort of, I think, explains how that improvement happened. Did it change behaviour in the health system? Yes, definitely, both positively and negatively. There was significant buy-in from ED doctors and many DHB managers. There was significant resistance from inpatient medical specialists on the wards, and there was considerable pressure on ED nurses who bore the brunt of the target. Did it establish feedback loops between outputs, processes and outcomes? Perhaps initially, but it's difficult to answer that question. What else happened? Well, gaming, to be short. We published an article on this in the International Journal of Health Policy and Management last year, and all our case study sites that we looked at, there was gaming, there was beating, there was falsification of figures. The main thing that people did was move patients that were about to breach the 6-hour target into short stay units. And this happened. I'm not saying this happened to most patients, or it may have only been a small number of patients, but it happened universally. And that stuff started happening more after about 2011, after about 18 months. So what really happened was there were real improvements. They happened early. Once, I guess, a plateau was reached and what could be done, that's when the gaming and cheating started. And it takes a while to learn that gaming as well. Immunisation target. This is a more positive story overall. Did it catalyse improved performance? Yes. If so, how? Well, basically it was immunisation coordinators from PHOs and DHBs getting together and working out how to find and how to deliver immunisation to the kids that hadn't been immunised yet. And they did that through utilising outreach services and putting in a phenomenal amount of energy and effort into doing that. Did it establish feedback loops? Well, not in real time, but it's pretty plausible that, you know, I mean, the issue here is we know that if you get increased immunisation, you will get the herd immunity the year after. But of course, we have had measles outbreaks. We have had various outbreaks since those targets were introduced. That's not directly due to the failure or otherwise of the or success of the immunisation target. What happened before that? What else happened? Well, Esther talked about collegial competition, intra-district learning and sharing of ideas, but also about, and reduction of inequities was very noticeable between Māori and non-Māori, but also target fatigue of those involved in implementation. And now that those rates have gone down overall and the inequities have reappeared, what we can say is there was a bit of a ceiling effect, and so it didn't stimulate a substantive shift in primary care practices to go out and find those kids that weren't being immunised themselves, or develop alternatives, or PHOs to sort of really build that into what they are doing. The elective surgery target, did it catalyse improved performance? That research would be very difficult to do. It would require different research to what Corinne did. I'm not sure how you do it, but anyway, interested in some thoughts about that. So let's go to the bottom 4 questions. Did it change behaviour in the system? Absolutely, both positively and negatively. You know, positive changes in data management, some real tensions in between managers and clinicians in DHBs, and tensions between primary and secondary care as well. Did it establish a feedback loop? That's difficult to establish without any information about outcomes. What else happened? All of the pathologies of performance management for accountability were readily apparent, and Corinne details them quite intricately in her thesis. Futility, jeopardy and perversity. Other comments, it's a very high, elective surgery booking is highly complex, so many moving parts. And what was really interesting in her thesis was focusing on the key role of service managers in basically putting themselves in between senior clinicians and senior managers and trying to manage what was a really nasty tension. The more hearts and diabetes check, did it catalyse improved performance? Well, all that Alan and Clark could do was try and see if it changed statin prescribing, which is, I guess, a proximate indicator, but not a great one, probably. Did it change behaviour in the system? Well, mostly positively. Improved data management. There was buy-in from clinicians. Did it establish feedback loops? No, because you don't really have good outcome data or even intermediate outcomes. What else happened? Significant transaction costs. Legitimised gaming. The ministry said okay to PHOs who just went through and individual practices registers and pointed out the ones that hadn't, the patients that hadn't had their CVD risk assessment, and that was sufficient for them to meet the target. Other comments, yeah, there was a focus on risk assessment, but not the follow-up, not on risk management. So, summarised targets. Keep an eye on the time. How are we going? Okay, we'll get to system level measures, so we've got some questions. Okay, that just summarises what we've said. So let's go to system level measures. Did it improve performance outcomes? We did. We looked at this by interviewing people across every district in New Zealand, bar 1 or 2. And the thing about system level measures, of course, the outcomes are very, very distant in most cases. So we were just looking at what could be done reasonably in the first 1 or 2 years, and that was mainly about processes. So it's pretty difficult to know whether system level measures have improved outcomes in any way. Did it change behaviour? Yes, it did stimulate plenty of collaboration at the local level between middle level managers and clinicians. It deepened and widened collaboration where good DHB and PHO relationships were already there, but it couldn't create good relationships where those relationships were not good to start with. Did it establish feedback loops? Don't think we found much evidence of that, but again, it would be too early to tell. What else happened? Well, there were some specific frustrations with how the funding in this program was allocated, and we published a paper on that. I don't want to talk about that in any detail here. And I attended a system level measures meeting in Auckland DHBs about a year ago, and what really struck me was the disenchantment that had set in into the process, but that may have been unique to Auckland, but I suspect it has happened elsewhere. I'll look at why that's happened. Anyway, so let's go back to the original questions. Performance management for accountability, health targets. Basically, most of the points in the case for and the case against are borne out, but not universally, and there are exceptions. So we can see examples of the same target stimulating real performance improvement, providing clarity of expectations, and also exhibiting futility, jeopardy, adversity. Now, the immunisation target was the one that was not gained, and I think that's important to understand why, because the implementers did not have control over the information, which was the case in all the other targets. It's an independent national immunisation register. For the system level measures framework, again, as a case of performance management for learning, most of the positive and negative points are borne out. You could say all those things about the system level measures program. Some of the more ambitious sort of benefits of it, they may happen, but probably only in areas where the data collection and management is really sophisticated. So that might happen, say, in Canterbury, for example. So the question of whether you can have your cake and eat it, well, say that perhaps in the case of the child immunisation target, you can. You can have performance management for accountability, and you can have performance management for learning. It may have been a bit of that in the ED target to start with, but that definitely worsened over time. The more accountability became important, the less learning there was, or unless you count learning how to game. But not real learning about performance improvement. And I think the heart and diabetes checks and elective surgery target say similar things. The system level measures, well, there's not an emphasis on accountability, but how much learning is there? There's a bit, it's patchy. So this picture, we don't sort of, Van Doren and Hoffman's broader argument isn't really borne out. It depends on the particular measure indicator. And we use Shang and Morton. Well, this gives us an explanation of what we've just seen. So the reason the child immunisation target is a case of being able to have our cake and eat it is because there's little contestation about the ends, and we know how to do it. So in that sort of case, it doesn't matter what sort of performance management regime you use, it probably would still work. But the other ones are not so clear cut and are much more in other parts of this map. So, and then we get to this point that this, if performance management is built on the idea that there is a self-contained loop between outcomes, outputs and processes, well, that condition simply does not apply in most real-world cases. Does to some degree in child immunisation, maybe some other child health examples. But as we've learned through many, many projects, the things that affect outcomes are probably much bigger than the performance management regime itself, generally. Even, Pushka's may want to talk later about amenable mortality, which is supposed to be amenable to what happens in the health system, but actually most of it isn't. Now, so the conditions for feedback loops are rare. Independent verification of data is another important thing, so I'll just skip over that. Just say, what have we learnt? Can we, the nature of the PM indicator matters much more than the nature of the regime. So you can have a good indicator that works, doesn't matter what regime you use. An indicator that doesn't meet those conditions probably won't work, either for performance management or learning. And then what happens in the middle? Should we use any sort of performance management when there's considerable ambiguity about the relationship between means and ends? And more broadly, I say, so what questions should you ask about a performance management indicator apart from whether it measures what you want? Can you demonstrate its effectiveness independently of the performance management process itself? A lot of the stuff about the ED gaming wouldn't have been apparent unless you actually went and tried to research it. You wouldn't get that information from the DHB's reporting things themselves, or the ministry for that matter. I think it's crucial to understand what any indicator does when it's at home, when you're not looking. Because that raises some sort of analogies with quantum physics and Schrodinger's cat, or at least the Hawthorne effect about how things change once you start observing them. And also, let's never forget the side effects of using performance management. So thank you to a whole cast of characters in this room. And let's open it up to questions. I'll stop sharing so I can see it. Okay, so how we do this? Got a few things in the chat, so I might look at those first. Okay. Right. So we've got questions about asking questions so far, which we can do. Who'd like to kick off? Rob?
Yeah, great, nice talk. It all seems a bit foreign to me because I'm not kind of familiar with the two different types of performance management that you're talking about. Have you lost me? Can you hear me?
Rob, I lost you there.
Can you hear me now?
I just changed the volume because it was very loud and disappeared.
Can you hear me now?
Can somebody try again? I might have to take it up to 100.
Can hear you, Rob.
You can hear me now?
No, I can't hear you. Well, that's weird.
I think other people can hear it, but I'm not.
Can you write your question in the chat and we'll try and figure it out? Sorry, Rob.
So other people on the Zoom can hear me.
So I'm in the Zoom and I'm talking. I'm pretty sure I probably can't be heard either. Tim, can you hear me? Okay. So it's the audio in the seminar room, not anything else, because I could hear you perfectly, Rob.
Okay.
The different styles of performance management, how those impacts might be mediated by the roles that the targets. So thinking about maybe the DHB overall management versus particular service clinicians. Is there any evidence that different styles work better at different levels?
Always a lot in that. I think what we see is sort of the good effects and the bad effects simultaneously. So you might be able to those to do stuff effectively if you have sort of more have sanctions involved, but you'll also breed resentment as well. But they might actually end up learning something along the way as well about what they're doing. So it's all kind of, it doesn't seem to be mutually exclusive, I guess, the positive and the negative effects. So can people hear, just in the chat, those of you on Zoom, can you hear Monique's question? Yeah, thanks. Richard can't. Okay. Well, this is going to be interesting. I don't know how I managed to shut you up, Rob. Can you put your question? Oh, you're there now.
You can hear me now?
Yeah.
Oh, okay. I was just going to say that my background's more on kind of program evaluation, and when you're doing an evaluation, you can't understand your outcomes unless you do understand the processes and inputs and outputs side of things. So it seems totally kind of counterintuitive that it's an either or, that we either do this and use processes and inputs and outputs, or we use outcomes. If we just focus on outcomes, we can't attribute any changes to what people are actually doing. Yeah. I know that, yeah.
Yeah, I know that's a good point. I think the difference is a little bit more subtle than that. It's more about where you start and what you start focusing on in order to sort of work your way back around the circle.
Yeah.
And I think, the difficulty with system level measures in implementation is you've got these outcomes, and even the ones they select for themselves, again, you've got exactly that attribution problem. And DHBs, PHOs are kind of making it up as they go as to what they think will influence these outcomes, and they try one thing and they don't necessarily see an effect, but you probably wouldn't expect to in 1 year. And then they try something else. So that's sort of dynamic that seems to be happening there. And of course, what you get with the targets is a separation often from the outputs become an end in themselves, and the sense of connection with the outcomes is often lost.
Yeah, like for example, with the cancer target, the faster cancer treatment target, the outcome that you might have for that, if you were thinking about it in terms of having an outcome, that would be cancer mortality. And there's so many things that drive cancer mortality. So it wouldn't make sense to have a performance target, a performance measure that was based around something that so many complex things fed into. And I think that's the problem with a lot of the measures that are being used.
Yeah, I mean, so the ones, I think it's a fairly small number of things where things are going to work. I think screening might be a good one. Screening, immunisation. So some of these population health interventions where you can measure the rates, and you've got an infrastructure to support that already. You've got, sort of some reasonable control over data quality. I mean, those, and they're kind of intermediate outcomes in a way. I mean, they're outputs, but they're more closely related to outcomes. So those are the, those are the low-hanging fruit, I think. But there's not a lot that fits in that category. Rich has got a question: is it reproducible? Is this study reproducible? He's laughing. It's because he knows that's a nasty question. Which bit? What we're trying to do here is just pull together the things that have been done. So I guess you've got to ask it individually about each study. is the synthesis? I avoided calling it a synthesis, so I don't necessarily think it is, but I think there's enough information to make some plausible inferences. And,
Tim, can I jump in?
Yes.
I've got a question around the Māori Public Health Agency that is being set up by the result of the Simpson report, and I heard an expert interviewed recently saying that they would like to see the success of this agency. It would need commissioning powers, and this expert said in order to have commissioning powers, it would need outcome-based performance indicators.
Yep.
And my first question, I guess, is, do you agree with that in terms of there's concerns if they don't have commissioning powers, how successful it would be to start with? And then I guess, what outcomes? The second question is, what outcomes would you measure? Obviously, Māori health outcomes, but indicators. But there's just got to be so much more to it in terms of everything you've just covered.
if you did that, you'd be setting it up to fail.
Right.
You're as simple as that. And
Yeah.
and I do think that a lot of the language here has been, you know, I agree with the broad sentiment about, you know, government has actually, you know, dropped the ball here. The health system has dropped the ball. Something needs to change. But to speak this language of accountability for outcomes is really, in my view, incredibly dangerous and stupid and self-defeating.
Yeah. And there's a really good comment come in here in the comment box about it, because it kind of gets to my point about performance management being a blunt tool. Yeah, I agree, sort of.
Yep.
So I guess how would we, I mean, there must be other places we could look to learn from, to understand how to measure, well, I don't know, but it just seems, it seems that if that is going to be the negotiating power to be able to be given commissioning powers, then it needs to also take into account what the you know, TR worldview and much more than simply just looking at numbers and statistics, right?
Yeah, well, I mean, you sort of broader debate about sort of the power of numbers when it's useful and you know, under what circumstances. I think that's important here as well. So yeah, performance management is a blunt instrument, and sometimes it is, sometimes it's not. We've seen lots of examples where it is. Again, I'd say the immunisation target, I wouldn't say that's a blunt instrument at all. That's a well-honed and very appropriate tool for the job. So all depends, I guess, on what's being measured, what the service or what the area is.
For me, I was responsible for the long comment in the box.
Yeah.
For me, it's about what the problem actually is and what's actually caused it.
Yeah.
If it's about mobilizing something that's there and just waiting, a measure that could, or a target that's put in place should work well, because it's just a case of doing what they know needs to be done. But most of the time it seems to be about culture, and performance management and targets as an approach seem to be a lot more about getting something specific happening, which is a different thing than addressing the culture. So I do wonder whether you get better value for some of these questions by just actually having a set of focus groups and other types of qualitative research going into the organizations and working out what's stopping the bottom-up solutions happening, because it's not that people in those organizations aren't going to have good ideas.
Well, that's interesting, because I think that's part of that would be entirely consistent with the system level measures approach, for example. Because the logic there is, here's some broad outcomes, but we're not going to hold people accountable for reaching specific levels. We're just going to say, okay, what sort of things, what sort of contributory indicators can you identify locally to that might shift those outcomes? So, you know, kind of, you look at childhood ASH and you might say, well, let's look at respiratory infections, and how can clinicians in primary care and secondary care trying to work out how to do services around respiratory services and preventative services better.
Yeah, I'm not sure though, because I think sort of the systemic problem, as far as I kind of see it, is that those bottom-up things can't actually happen.
Yeah.
Or something's actually blocking it, and having a system level measure doesn't necessarily mean that those obstacles got rid of.
No.
Unless the people at the top know what they are, then whatever they're deciding at the top is going to potentially be misapplied.
Yeah. Yeah. I mean, but bear in mind, yeah, I mean, and the thing about bottom-up stuff is bottom-up stuff doesn't join up, generally.
No. Well, the thing is, it won't be the same solution in different places.
Absolutely. But that's what you get. You get lots of good ideas locally and lots of local places where no good ideas happen at all.
Yeah. But the problem is that sort of the places where the conditions are right for those good ideas to come through are also going to be the places where things might work to a degree top up. But if it's not right locally, then none of these measures are going to work. It doesn't matter what you do.
And the culture thing, I mean, our take on that with the system level measures research is, where that worked better in terms of stimulating the processes that people wanted, the people in the ministry wanted, was where the relationships between DHBs and PHOs and other organisations were already good, and then it actually served to deepen and widen those good practices throughout the organisations, but it did not have any effect where the DHBs and PHOs were fighting each other, or which is close to.
But for me, things like the Māori Health Authority, if the systems that are in place are fundamentally opposed to a framing that would allow this stuff to work, you're going to run into the same problems. It's just it effectively becomes another layer going into the argument.
Okay.
Something that's going to solve it.
Okay.
Talking too much.
Thank you, everyone. I'm going. I have to go to the Staff Student Consultative Committee, and there's many people have other meetings. So thank you, everyone.
I think in the same room as you're currently in.
Yeah, we got there. Cool. See you all.
Thank you, Tim.
Thank you, Tim.